So this is the second episode of the healthcare webinar series. This episode is on interoperability, and I guess a focus on FHIR, but just interoperability in healthcare in general. A quick about us for Ionix. We are a technology company. Our design first approach is basically we have an excellent design team, both in UI and UX, led by Chippy, and we work in health tech, fintech, and Web3. So, of course, I lead the health tech, and we have great leaders for the other ones as well, Sean for Web3. And about myself, I am a physician. I've worked as a clinical product manager at an EHR company, which was last week's webinar, if you want to check out the VOD. And I've also worked as a physician consultant at Accenture, where I worked across the entire spectrum of healthcare. So I've worked in insurance, I've worked on quality-based care, worked in actual patient care as a doctor, and as a product manager, worked nearly exclusively on medications, so e-prescribing and things like that. I currently consult for a lot of different companies, as well as institutional investors that are looking to invest money into the US healthcare market. And I lead the healthcare vertical at Ionix as well. So before we get into kind of what interoperability is now, thanks guys. I wanted to start off with what is, interoperability in general. So I like to start with interface. So I think of that as the precursor to interop. So if you Google interface, they say it's like a bridge that lets two programs share information with each other. I feel like that's accurate. And what I would also say is the data isn't synced in real time, but you can map the data from one system to another. So when you kind of receive the data, you can say, all right, this goes into this place and this is where you display it. And it's like work each time the data flows in. And so I guess the mid-level, what we're talking about now is interoperability, which they talk of as like a data exchange. So it's kind of one level up from interface. So this is the ability of two or more systems to exchange data and interpret it once it's received. So I usually add, there's like also, let me say, if you Google this one, you'll get really technical explanations. Even the Wikipedia has a really kind of like robotic sounding interoperability definition. I think I have it here. It's like, interoperability is a characteristic of a work product or system whose interfaces are completely understood to work with other products or systems at present or future in either implementation or access without any restrictions, which is a mouthful and it's kind of hard to understand what's going on. I usually feel like just in the present state of the system, these two different systems can exchange data. So I say in the present state because it's like a future update or a past version may not be able to work seamlessly as this goes. I've seen examples of this with trying to explain how this works. I think a good one that a lot of us would understand is plugging your mouse into your PC. I remember the days you had to plug in your mouse. It would be like USB device detected. You'd have to, find the software or put in a disk drive, floppy disk or something and run something. Now it's like it gets recognized as a mouse. It runs, your computer. You don't have to click anything in it, and it understands that you have a mouse plugged in and it works, right? So it's still two different systems. Every time your mouse moves, it works to your computer, but it's the data is flowing very easily without you having to do anything. And then finally, integration is like the next level beyond interoperability. This isn't really that relevant, but I just added it here because it's good to see the three levels, I think. So this is when the software product works as a single solution instead of passing information between different systems. So this is like one system containing the same code, the same database, and these integrated systems work tightly together as the pieces of the whole are a single system. So The biggest difference here, I think, is that versioning is no longer an issue. It's a single system, and as compared to interoperability, where I said in the current state. So we'll move on to the actual thing that we're here for, which is HL7 FHIR. So this is the big name in the room these days for the last, I don't know, 6-7 years. This is what I've been hearing the most. It's going to do all kinds of great stuff. Of course, it's been around for a few years and I haven't seen the impact quite yet. But just real quick, if people don't know what HL7 is, HL7 or Health Level 7 is a set of international standards for the transfer of clinical and administrative data between software applications used by various healthcare providers. And FHIR was architected by someone there named Graham, and he leads the healthcare data exchange team and is the FHIR product director at HL7. So here's a few of the things that we'll discuss right now. It is that it's an open source standards framework, and it built from the previous HL7 standard. So HL7, like I said, is that a set of international standards, and they had version 2, version 3. They had CCDA, which is still used by a lot of information. So you will see that when they created FHIR, it was like to make healthcare data easier to move from one system to another. They tried to create a lot of kind of services that would work independent of which system needs to access it. Anyone can just hit this API. And as I talk about the API, you'll see that one of the key benefits here is that the use of RESTful or REST API as the basis. And so therefore, if you have a consumer mobile app, you can use get to request to retrieve a record, post to create one, put to update, and delete to delete one here as well. So if I am just using FHIR in my kind of consumer mobile app, there's a lot I can do as well outside of the core system of EHRs and pharmacies and things like that. And this last one is, again, kind of maybe it's marketing or whatever it is, but it is that FHIR eliminates the need to individually modify the data template of every health IT system by exchanging data as resources. And it does expose resources as patients, admissions, and medication services. And we'll look into what exactly is going on in the real world. So the business case for having FHIR, I think, is fairly easy to understand. I just kind of outlined it right here. It is that the health data that your primary care physician captures, it's kind of stuck in their EHR. While it is true that if your specialist happens to use Epic as well, for example, they will be able to access the data at your primary care physician, but it's like a walled garden, right? Epic wants everyone to switch to Epic in order to get access to it. They don't want to open it up to other EHRs because that's kind of their market share. They want more people to be kind of stuck in their system. So here's if your specialist is at a hospital, or if your specialist isn't at a hospital, if they're working out of a clinic, they're probably not on Epic at a clinic. So they're probably using ambulatory EHR software. So that will not transfer over, and they won't easily be able to look at what the previous data was. Same with lab tests. So if the data doesn't flow easily from the lab to your doctor's EHR, they won't be able to review them. So again, that's kind of like my doctor orders a blood test, for example, and I go somewhere, I get it done, and it may not go back to the doctor in their EHR to look like here's the result of the blood test. Could come as a PDF or something else that I would have to share to them, or would get shared to them in an email, which again won't be easy for them to view when I go back in to get a checkup or to get my labs looked at. And then for prescriptions, again, prescriptions are done in the EHR, so the doctor will see you and generally e-prescribe and send your prescription to the pharmacy. You go and you pick it up. But a lot of that information lives at the pharmacy. So did you actually pick it up, which is called a fill? So yes, I can give you medication for your heart issue, but I should also know if you picked it up or not. Because if you didn't pick it up, it's a note for me to follow up. Like, why didn't you pick it up? Is it too expensive? Are you having issues with something else? Did you go to the wrong pharmacy and it's not there? So it's kind of like a note to the doctor, like, hey, like your patient's not taking the medication. Same thing with refills. It's like how many refills are remaining. You're supposed to be taking one a day, and I gave you 90 in this prescription. So I should kind of know when it's going to end. But if there's refills, is that going to also tag in my system? Generally, in the doctor system, the medication list won't auto expire or anything. So it'll just show me what medications you're on. I won't know if you need a refill. I'll have to kind of talk to you and figure that out. And of course, all of this causes fragmented data, so that when you do go to any of these providers, when you go to the pharmacy, when you go to your doctor, it is likely that they don't have a holistic picture of your health because all the data is split up between different systems. So this slide, I use an XKCD comic, and this is the business case for FHIR still. So if this FHIR single standard is such a game changer that's going to bring together the data from your doctor, from the pharmacy, from everywhere, then why isn't everyone already using it? This comic is a little bit simplistic. I won't say this is the only thing, but yeah, so you'll see that here there's 14 competing standards, and in the middle, I guess this would be the HL7 folks. They're like, oh, it's ridiculous. We need one single standard that covers all the use cases. And soon there's 15 competing standards. So right now, the estimate I've seen for FHIR is that it's used for about 5% of message flow. So that's a very low proportion compared to HL7V2, CCDA, even X12 is even higher than FHIR today. So why are the reasons that everyone hasn't adopted this? Other than this fun comic here, the real world ones are really that if you're already using something else, it's a big effort to change. So if I'm using HL7V2, I don't want to have this huge implementation to add FHIR because I'm already running this software, and I've been running it for years or even decades in some situations. So actually, the large institutions will only implement what is necessary. So if there's something passed that says, hey, for HIEs, you must use FHIR, they will create a small FHIR system, and they'll go live with that just to meet the requirements. But they don't go back for a large project to update their existing HL7V2 or CCDA. And another complaint I've seen with FHIR, even though it uses a single standard, hospitals can still use the data sets differently. And there's no requirement on how to label field values. I'll just give one quick example. So blood pressure can be labeled BP or blood pressure, and different systems, even though they're calling the same thing, they might be stored slightly differently. Same thing with procedures. So procedures, I've heard, can be very differently stored in FHIR. You might want the start date, date period, end date. Like there's multiple dates that you're kind of adding, and you might want different things. And if you're pulling a date, you might not know exactly what you're getting. And it's honestly just a really big lift because many EHRs are on old stacks and are never updated. So if we think back to the interoperability versus interface kind of slide, it's that it's difficult to bring up those old systems to a new standard that they're not compatible with. So if I'm updating my one system to FHIR, it's a little chicken and egg, like what's going to happen with all the other systems that aren't on FHIR. It's not kind of like a singular backwards compatible thing or anything like that. So it is something that needs to be implemented widely. And that's another one of the things stopping it from being the game changer. And we'll kind of look to the future. So other than FHIR, I've heard a lot about Web3 and its interoperability, and I've heard it a lot more recently as Web3 is going to be the thing that gives us ownership of our own data. This is true for in Web2, I guess, what we're using now. A lot of the companies, Facebook and things like that, our data of how we surf the web, how we use things, what we click on is highly valuable, and they use that to sell and all kinds of things. So Web3, it's still nascent. So I believe we're still yet to see how we will take the power of our data back. There are use cases, but as we saw with FHIR, a great use case isn't enough. We do have a thought leader in this space at Ionics, who is Sean Ray. He's the head of Web3 partnership. So I did speak with him about what he thinks kind of the future of healthcare could be. But as far as the use case here, it is that the decentralized kind of business model revolves around handing over to users ownership of their data, and it is putting the community first. So I don't know about this whole EHRs from siloed centralized to interoperable patient owned. It could solve a lot of problems, but again, how will it be done? It would be nice if I just carried my records around with me, and wherever I went, they would be able to view them. But the transition to that seems much, much steeper than even the transition to FHIR. So we'll see how it goes in Web3. I am hopeful that we're going to be able to get something cool out there. And I'm going to share another use case that I see right now. There's a DAO. So DAOs are kind of like businesses in Web3. They're a decentralized autonomous organization. So it's kind of like, I don't want to get too much into DAOs, but it is a Web3 organization. And there's one called Love DAO, which was started by a billionaire. And his aim is to crowdsource pharmaceutical research and development. They already raised $7.5 million at 180 million valuation. So, right now it takes years and tons of red tape and a lot of different trials to get a medication to market. So he wants to crowdsource this. And I am part of their Discord and kind of trying to see how that goes. Hopefully something does come up with that. But yeah, I think Web3 has a good shot. Like I said, it's still nascent, so we'll see. But yeah, it is the future. As far as how we can help, we can implement any of these standards as well. If you are looking forward to adding FHIR to your consumer app, we can help that get done, and you can pull everything. It is open source, so it is quite easy to get running. Hopefully, there's enough systems that you can talk to and get information from that you need. Also, we also do Web3 health consulting. Like I said, Sean Ray is our head of Web3 partnerships, and I work closely with him, and I'm talking to him frequently about what's going on in Web3 health, refining clinical workflows, custom technology builds. So we do digital health and apps. We've done some cool stuff in the past, which we have a deck I can share. Prescribing, e-prescribing optimization and development. Like I said, I'm a deep specialist in this area. I worked as a clinical product manager on e-prescribing. We also do a technical review of EHR software. So if you have an EHR and you're looking to update it or get some of the back end cleaned up, we can do that as well. And in general, we are a technology partner for health tech. You'll be able to work directly with me with whatever project you're looking at. So feel free to get in touch. Here's my info, which I'll just keep on the screen. And if there's any questions or anything, I will look at the chat now. Otherwise, yeah, hopefully this was helpful for anyone. As healthcare standards, we have a question. As healthcare standards evolve and regulatory requirements grow, is interoperability becoming more of a challenge? It is becoming, I don't know if it's more of a challenge, but like as these regulatory requirements grow, I wonder if there's going to be a tipping point at which companies won't just do the bare minimum. Like right now, when Epic needs to use FHIR, they'll create a small, like I said, FHIR system that will meet the regulatory requirements. but they won't go back and update everything because that's again a huge lift. So maybe if it becomes enough of a challenge, more people implement it. I think another problem is it going to be a challenge of like, oh, this is a burden because I want to do other things, but now I have to go and implement FHIR, which is a real thing as well. You don't want to just have all of these requirements, created by bureaucrats, especially. We saw it last week with EHRs as well. They were kind of created with a lot of goodwill and thought towards reducing dangerous medical mistakes. And in the end, they just created, 4.5 hours a day of doctors treating the computer screen rather than treating patients. So I think that's definitely one thing that we'll see. One other question: will APIs play a significant role with meeting healthcare interoperability goals? I mean, APIs are pretty ubiquitous anyways. So I think in the future, we're going to be seeing more of that for everything, even for kind of like drug databases, which used to be downloaded on a monthly basis and updated manually. Everything's just kind of on the cloud now. You just call the API of what you're looking for, and it spits you back, like a JSON object or whatever you're looking for. So it'll have that. You just parse that and you get the data you need. And the response times are really low. You have really high uptimes and everything. So yeah, I think going forward, API is going to be the biggest play. We're not going to see a lot of other things in the near future. All right, I think those are our only questions. Yeah, let's see. Yeah, feel free to reach out. I am pretty available. I will respond to you. And looking forward to connecting again next week for our next episode. And all right, thanks everyone.